go. Yes, it is recording. Okay, great. And you also know that the person who attends the most of these live and in person is going to get a $25 gift card. And for those of you who are going to be keeping track, I know this is a competitive bunch. If there's a tie, we'll do some sort of random selection. I promise I'll be very fair. Hi, Dr. Yost. Hello, hello. All right, awesome. I'm going to jump right in and get started. Please feel free to eat. I know this is lunchtime. Everybody is muted. That's great. And if you want to participate, you can always unmute. You can use the chat. Probably hold questions mostly till the end, just so we can make sure that Sarah and I get through all the information we need to get through. For those of you who missed it, I think everybody knows who I am, and that these are the integrated care seminars. And then this is Sarah. She's a social work student who will be helping me present today and help me put together this awesome presentation. And we already talked about attendance. And don't worry about getting down details because everything's going to be recorded. I'll send out a copy of the slides, and I'm going to send out a quick handout for reference too. So you can just focus on any questions that you might have and absorbing the content, and we'll get right to it. All right, Sarah, you can take it away.
Right. Do you want to go to the first?
Yes.
Thank you. The teamwork. All right, so as Dr. Alto said, today we're here to talk about serious mental illness and how we handle that in a primary care setting. So serious mental illness can present in a lot of different ways. It's less about the specific diagnosis and more about the intensity of symptoms and how they are impairing an individual, specifically in their activities of daily living. So schizophrenia is kind of the most common example, but this could also look like chronic PTSD, bipolar disorder, and in some cases, even really persistent depression. So in 2019, among the 13.1 million adults with SMI, only 8.6 million, which is 65%, were actually received mental health treatment. And as many as 70% of primary care visits tend to be driven by patients' psychological problems, which I'm sure all of you have experienced, kind of patients wanting to talk about anxiety, panic, depression, life transition. So just a good reminder that a lot of times these mental health issues do come up in these primary care appointments. One model that we have been thinking about is called assertive community treatment, which some of you may have heard of. It's an evidence-based practice that really strives to serve people in their environments, and it's an interprofessional team that works with people. So a social worker, primary care physicians, nurses, occupational therapists, it's really around the clock services, and the team works together to kind of determine what each client needs. And when done effectively, it's shown to have a significant effect on lower hospital stays for patients, reducing homelessness, substance use, and even being really helpful for burnout for practitioners. So obviously, here at Neon, we're not really in this assertive community treatment setup, but there are things from this model that we can utilize. The primary one being that we can be kind of a one-stop shop for patients. So we have primary care, behavioral health, kind of even though we're not fully integrated, we are here supporting each other. And building trusting relationships with patients is something that can really go a long way when you are dealing with serious mental illness. So just being a familiar face, providing some consistency for patients, and then also connecting to families, because a lot of times patients will have, a family member with them or even a close friend, and just getting whoever they trust involved in their treatment can be revolutionary. And then another thing I wanted to highlight just on that last slide was that we do in behavioral health have a lot of psychoeducation handouts. So if you're seeing a trend or really interested in getting some extra support on that, you can contact Dr. Alto and we'd be happy to send you some resources to just hand out. Right. And then talking about Neon as a patient-centered medical home, sometimes it really feels like we might not be the best place for a lot of these patients that we're seeing, but we really want to empower people to think that, we are the best place to start, because we can't be everything to patients, but we can make those referrals and kind of just be the first step to proactive healthcare instead of being reactive. So oftentimes, again, as I'm sure many of you have experienced, PCPs can be the first ones to really detect SMI, and maybe the only consistent provider for someone. So if they're not connected to psychiatry already, or don't have like a treatment team, you might be like in the first line of interaction. So again, getting the family involved is something that first step that's really, really helpful. And just remembering that you're treating their health problems, which community mental health providers, even if they are connected with, they're not addressing those really chronic and acute problems. So you are just simply by treating their health problems, even if you don't know really where to go with the mental illness, making a huge, huge difference. And then we can refer to psychiatry outside of Neon at the moment, but we also have behavioral health and social work here. So if you need extra support or getting patients connected with more long-term care, we can help with that. And then the main point we really wanted to drive home is that like safety is huge for patients. So just really making people feel like they can trust you and they can talk to you, because a lot of times they might not know what's going on with their health or with their mental health. So you just being that person that they can consistently connect with goes a really long way. And then in terms of why medical care is so important for people with SMI, they tend to die 10 to 25 years earlier than the general population, which is kind of astounding. And when we look at statistics and look at why this is happening, researchers have found that a lot of times it's untreated chronic like physical conditions. So heart health, like respiratory, infectious diseases, diabetes, hypertension, they aren't being treated, and these are a lot of times entirely preventable diseases. So because of coordination of care and just inconsistency with like treatment providers, like a lot of times, again, PCPs are the people that they come to the most. So again, just you treating those basic health issues, it goes such a long way. And another thing is just making certain psychoed practices that we would just make to the general population available. So one common thing that we see is that for smoking cessation, obviously smoking really impacts people's health, but there's usually so many pertinent things going on with someone with SMI that we might not think to talk to them about stopping smoking, because it just doesn't seem like the most important thing to address. But that small shift or just putting that into their mind could be like a huge change for them. And even if they can't follow through right then, we still need to be giving those recommendations within our limits. But it ties into self-care too, because people with SMI sometimes do have poor self-care habits, or just don't get enough exercise, do use tobacco at higher rates, and there are risk factors like unemployment, isolation, all of these things that can just really add up. So we do understand there's a lot going on, but these little things really do help in primary care. And because we're talking about all of this, how do we actually recognize when we are seeing someone with a serious mental illness? And the best way to start is just with the universal screening. So really being direct about mental health, because sometimes it's easy to talk around it, but just asking, like, have you ever received a diagnosis of any of these things, like schizophrenia, bipolar? Like, what does your family say? Do you ever have like mood swings? And of course, everyone knows just like the basic, mental health questions to ask, but definitely asking about hospitalization a lot of times can be a big like signifier that there's something going on. Being aware of psychiatric medications if the patient is on some, and just asking them like, hey, next time you come in, could you bring your medications with you? Something that's helpful even for us in behavioral health is just looking at the notes in NextGen, because maybe someone's been in 5 years beforehand, or just has 1 or 2 interactions, but we can glean some information from that. So, and of course, we're always updating too when we have patients. So if there is overlap with behavioral health and primary care, that's great. And then just noticing like unusual behavior, maybe difficulties in like recalling things, memory, cognition, that sort of thing. And then Dr. Alto, I Now you have a few examples of this from the past few weeks that you wanted to bring up.
Yeah, I thought it was interesting when I was preparing for this presentation because it seemed then like the universe wanted to prepare me by giving me lots of some real life applied examples here at Neon. And I don't know if Katie's on the call. I don't see her, but we had somebody last week who presented in OBGYN who came in holding baby dolls and seemed to be treating the baby dolls as if they were her real babies. So that was kind of obviously a big red flag for SMI. And that made it pretty obvious as something that we needed to follow up on quickly. But it was interesting too, because this is someone who has like engaged intermittently in care at Neon for years, but we didn't have anything in her medical record, anything in her chart about pertinent psychiatric history, because it's something that had never really come up, in that, she wasn't bringing it to us and maybe it wasn't presenting itself, but obviously it did this week. And my main intervention with that was to kind of get an assessment of what was going on, which did seem that she was having some sort of psychotic symptoms and delusions related to the babies. And I was able to get in touch with her mother, who was able to give me a really good comprehensive psychiatric history where she was getting treatment. And we also were able to recognize that the biggest barrier for this patient right then, so she was engaged with services at Metro, and it was great to, now we know who we can call about that in the future, right? Get that provider's name in the chart and on the record. But the biggest barrier for this patient is that she hasn't been going to her, she has a home health aide who comes and gives her psychiatric meds and makes sure that she gets the shot, which often isn't there when the home health aide shows up. So it's good to know that for this patient, that's the biggest, most important intervention, is making sure she's consistent in following up with those services. And it took some investigation, but it wasn't that hard to kind of figure out who those services were once I got the mom involved, who was able to give me a lot of that information. And it helps us understand some of her presentation to know what some of the things she might be coping with. Another example that just came up with Dr. Carter yesterday, and it's interesting that the most interesting or challenging cases always seem to show up right at like 5:15. So this was another example of that. But this was a patient who Dr. Carter had been dealing with on and off for a certain issue that just seemed to the patient couldn't let it go. So it was about a medication that she'd gotten from another provider. The patient was very upset about this medication. She was very concerned about it. She didn't understand, it wasn't her normal doctor who gave it to her. And this is all outside of Neon. It was a different doctor, and she didn't understand why it was that doctor. And she just kept asking over and over and over again to everybody here, but why is his name on this medication? Why did he give it to me? I can't take it because it's not the right medication, because it can't be, because he's not my doctor. So and we actually had her fill it. And because of insurance, it had already been filled under the other provider. So we couldn't switch. You couldn't then have Dr. Carter prescribe it and fill it because it's already been filled. And so she went to go get the medication from the pharmacy, and she actually came back and brought it to show it to us, to show that it had the wrong name on it, and just really persistently very, very concerned about that medication. And that was one of those things where we don't know a lot about this patient, and I still don't know exactly what's going on yet, but I think there's some pretty clear red flags that there's something going on there in terms of that persistence and paranoia about the medication. But with that, the key thing is just trust. If we can get her to come back and trust us and trust that we're going to help her and take care of her needs, and that we believe her concerns. And I was like, it is so concerning that you don't know who's prescribing these medications, right? We want to make sure that that won't happen to you here, because if you keep seeing Dr. Carter, then you'll only see her and the medications will come from her, and providing that reassurance and consistency, but not trying to argue with her, because there's arguing about whether or not it's the same medication when she believes it's not, isn't going to get you very far. So those are just two examples that have come up recently in terms of how SMI presents. So sometimes we know a patient has SMI, we've known it forever, and we have varying degrees of information about their other sources of care, but sometimes we don't know, because you're there to talk about their hypertension or other things and it hasn't come up. And Patients don't always come in and say, hi, I have a history of schizophrenia and I'm on an antipsychotic. And I was diagnosed 20 years ago, and this is my treatment history. That doesn't happen very much, right? Especially because part of the characteristic of a lot of these illnesses is a lack of insight and struggles with memory and cognition and communication, which might make it difficult. So sometimes it's more on us to catch these things and coordinate with other people to get that information. So with all that background, what is the role of primary care providers? So I'm going to go over 5 main roles: coordination of care, addressing stigma, maintenance and relapse, responding to acute crisis, and physical health. So care coordination. So this is about understanding all the different places that your patient is getting care. Who are their different providers? Where are they? Who are their different medications? Do they have a case manager? Where are these things coming from? Now that sounds easy, right? We all know it's not. And there's definitely some tricks you can try. Obviously asking them to bring their medications in can be tremendously helpful because you can see the prescribers on the medications. Getting the support person is the absolute best intervention that you can accomplish with someone who has SMI of any kind. So that support person may be a family member, it might be a case manager, it might be a neighbor. It could be a lot of different people, but figuring out who that is. Sometimes I ask different types of questions. Oftentimes, if I ask who helps you, or obviously you start with who lives with you, but it is harder if they live alone, or you say who helps you, and they often say no one. But sometimes they'll say no one helps me, but then later they'll be like, oh, my caseworker or my mom brought me to this appointment. So sometimes you have to ask the question a couple different ways. And then once you know who that person is, being like, would it be okay if we involve them in your care? Because I think it's so helpful if I can know everything that's going on. And then getting their permission to have them involved in care, you're going to get a lot more accurate, collateral, helpful information from that support person, and you can use them to reinforce interventions as well. Another thing is that with care coordination, let's say you're referring to me or you're referring to social services, et cetera. Awesome, we love the referrals. Thank you so much. We can't do anything with a referral if we don't have an accurate phone number. So I will sometimes literally ask patients who I'm really worried about their cognitive impairment, worried about their ability to communicate, is I will literally say, can I see your phone? I just want to make sure I have the right number, and I will get the right phone number, make sure I have it from that actual phone that they have with them. Because oftentimes we know that the phone numbers don't get updated for a lot of different reasons. Patients, even at the front desk, when they ask, oh, any changes to your phone number? They're like, no. And then I'm like, is your phone number still this? And they're like, no, it hasn't been that for 4 years. Like, well, you forgot to tell us. So getting that updated contact information is sometimes the most critical intervention that you can have, right? Because if we don't know how to contact people, we definitely can't provide service. And then following up on referrals, whether they're internal or external, and we'll talk about some external referral options later. It's not just one and done. So we know that patients with severe mental illness, and really all patients, have a hard time following up with referrals. There's barriers. They might be confused about what the referral is for, especially if you have a referral and you're able to communicate with a support person, that can help a lot, right? So if the person who drives to their appointments knows that you want them to go to recovery resources, that's great. But if the patient is responsible for that information, that might be a lot harder to pull off. So the art of a referral can be figuring out who you give that information to and following up next time you see them. Hey, were you able to go? Oh no, what happened? Like, what can we do to help you make it next time? And kind of problem solve from there. And behavioral health is happy to help with that process. Requesting records is also a really great way to get collateral information. If you know somebody was recently hospitalized, or they follow up, use that records request that's right on the back of the patient, what do they call those? The check-in forms, the ones they bring in from the front desk. You can use that release right there, get it to medical records, request those records, and then you get a lot more really helpful information that can help inform our ability to take care of these patients. So in addition to coordinating care, we also want to acknowledge the stigma that impacts this population. People with SMI are human beings worthy of dignity and respect. And this is just one part of who they are, but oftentimes it's the only part that people see, or the only part that people talk about. And one of the reasons why they might not tell a primary care provider can be some of the things I mentioned before, like lack of insight, but it can also be just because of shame or embarrassment, and they don't want to share with you that they have this diagnosis or they take pills for being crazy. They don't want you to know that about them. So we have to create non-judgmental, safe spaces where patients feel comfortable sharing this information with us. And part of that is by directly asking about it in a non-judgmental way, because that creates a sense of like, it's okay to talk to me about this. Like, it's part of my job. It's part of the human experience. That's why I'm asking about it. And, I think it's really important we talk about some of the myths that go along with this population, that they're beyond help, that they can't understand or make decisions about their health, that they don't know anything about their illness, or that they're violent or dangerous. So the first one, that they're beyond help, we actually know that SMI, although difficult to coordinate care because of the barriers we're talking about, is extremely treatable when you have the adequate support in place. At the same time, you can look at famous examples like Kanye West, right, who has bipolar disorder, one of the wealthiest men in the world, but he still struggles to manage his symptoms. So we know that even with all the resources in the world, SMI can be difficult to manage. But we also know that there are people with schizophrenia or severe bipolar and PTSD who are doctors and lawyers and who have the right treatment plan, medication, therapy, a supportive environment, and who are able to function excellently and do a lot of wonderful things in the world. And so I think it's important to keep that in mind for our patients. And their mental illness may or may not impact their ability to understand their health conditions, but you shouldn't assume that they don't understand, or assume that they lack capacity. So some might. That's something you can consult with us about, or obviously if they have a legal guardian, then the court has found that they lack capacity, but it doesn't mean they don't have a right to have preferences or opinions about their care, and we should still be talking to them and with them and not just at them, which is something that easily can happen, especially when we're talking to family. And finally, there's a lot of evidence that people with SMI are actually more likely to be abused and victimized than they are to be violent. However, if there is a patient who has a history of being violent during a crisis, that is something that we want to take seriously and make sure that we're addressing, because that is a safety concern. But a history of violent behavior is more of the red flag than the serious mental illness itself, because most people with serious mental illness are not going to be a danger to other people. And about understanding their illness. So I think that sometimes we never, like, we have a patient with schizophrenia, it's in their chart, we know they're taking medication for it, but people will never actually say schizophrenia to the patient because they think it's like a bad word, or that the patient doesn't know, or they don't want to upset them or embarrass them. I think it's really important to create that sense of that this is, oh, like, I see here that you have this diagnosis, like, why don't you tell me about what your treatment is for that? Or tell me more about that diagnosis. Like, it's okay to talk about them. You can see how the patient understands their diagnosis is actually really helpful to understanding how they might be doing in terms of stability and their treatment. Sometimes using specific labels can be confusing for patients who don't identify with those labels. Sometimes I say things like, your brain chemistry might not work the same as other people, and you need medication to address that, or sometimes you're not like yourself. And a lot of patients will use the word like breakdown or crisis to describe themselves. So it's okay to use the same language as the patient, but it's also, we don't have to shy away from using a diagnosis if we have a diagnosis, and asking about it, asking about how they're doing with managing their depression if we know they have a history of that. And that can be really helpful at addressing that stigma. So I think the most important role, in my opinion, in terms of primary care and SMI, is that for your patients, and these are not the patients you thought about when a lot of you requested this training, and I don't think you were requesting this training for these patients, but these are for your patients who are stable. So patients with SMI who are getting appropriate medication, have appropriate support and environment. We want to keep them that way. And primary care has a huge role in keeping that way, because you have the ability to coordinate that care, know where they're getting treatment, know what their diagnoses are, know what their medications are, check up on, have you seen your case manager lately? Are you still taking this medication? Do you need a refill? We all know that people can go from stable to crisis downhill really quickly. And we saw a lot of that during COVID because people lost access to their care. And people who were completely stable and hadn't had psychotic episodes in a long time just went downhill really fast. So in primary care, if you're really being proactive, you can be the person who stops someone from going downhill. You can alert their mom that they've stopped taking their medication. You can make sure they reschedule with their psychiatrist because they've missed their last 2 appointments and you realized that. You can also encourage all the things we know work, which are using a pill box. You're going to hear me say that a lot. I love pill boxes. Pill boxes help people stay adherent, especially people who have barriers to adherence like SMI or cognitive concerns. Consistency, routine, structure, caring relationship, avoiding drugs and alcohol, all of those are good things that help people with SMI stay stable and stay on track. And if we're investing energy into these things and following up on them, then it will prevent the crisis part. But oftentimes we don't worry about the SMI until people are in crisis. And we do need to have a plan to address that. So how do we address it when people come to NEON in acute psychiatric crisis? Sometimes we know these people, sometimes we don't. Sometimes this is the first time you've met them and they're coming in an acute psychiatric crisis. It's hard. The important thing is to mirror that calmness so that the patient can also feel calm. You're calm, cool, collected. I always say that the more a crisis comes, and I'm a fast talker, you guys can hear me talk fast, and sometimes I can be kind of high energy. But when there's a crisis, I get really slow, really quiet, more relaxed. The more agitated and worried someone else becomes, the more calm you're going to become. And really emphasizing that safety, because people in crisis often do not feel safe. Emphasizing that you are safe here, we're glad you are here, we're glad you're telling us about what's going on, even if we don't really understand what's going on, and treating people still with dignity and respect. The biggest thing is connecting to psychiatric care ASAP. You can do that a variety of different ways, and it really does depend on the patient about which way is the most effective. So if they already have a provider, remember, if you already did that prevention work and you know that they see recovery resources and that doctor over there, let's call them right now. Get an appointment scheduled. Or let's talk to the support system, which hopefully you already know because you did that prevention work and the support person can help them do that. That's definitely the easiest if you already have that background information. Getting that information when someone's in acute crisis, you can try, but it's pretty hard, right? So if someone's in acute crisis, they're not really able to tell you, yes, this is my doctor, this is where I go, and this is the medication I take. You have to remember that antipsychotics work pretty quickly, right? So if someone's presenting an acute crisis, it really could be that they missed their pill that morning. And the only thing they need is to go take that pill. So again, if you know they're on an antipsychotic, you know that they have it at home, that problem solving looks really different. Oh, did you take that pill today? Oh, do you have it? Do you need a refill? Are you able to go home and get it? Do you have it with you now? If you know that that patient has that medication, then addressing, that's the most likely, quickest way to address it, right? So you can go to the ER, sure, but really what they need is to take the medication that they already have and that they're already prescribed. For patients that you really have no idea, Recovery Resources has walk-ins, and I'll give you a handout with exactly where they are and the numbers for how to reach them out. They have walk-ins every day, I think till 2:30, is that right there? So if, especially if this is a morning time and the patient may have the ability to get there or someone can take them there, that's a great way to connect to care quickly. But it's not very helpful if they already have a psychiatric provider somewhere else. So again, that's where it's like figuring that out can go a long way. Patients who need a higher level of care to stabilize, we have some referrals for those too that I'll go over. And those are patients who really need to spend some time in either several hours a day in treatment or even residential treatment. They're really not able to care for themselves. And we want to connect them to that as soon as possible. So ER is an option, especially for patients who are an acute risk to themselves or others. We can we can and should be coordinating transportation in those situations. We can also encourage patients to go to the ER as a way to get psychiatric care promptly. However, you might be disappointed. So when patients go to the ER in acute psychiatric crisis, but they're medically stable, ER docs might say, okay, here's our phone number to call for a psychiatry appointment. Give this a call tomorrow. So the ER doesn't always do exactly what you want it to do. And it might be, if what you think they need is to connect to a psychiatric provider, there are probably faster ways and more efficient ways to do that without going through the hassle of an ER. But again, if they're so disorganized and you're concerned about their safety, you might have to do something else. And we've said this a million times, but the more you can involve a support system, who can I call? Who's in your phone? Who could take you to the hospital? The easier this is to help in a crisis, because someone who's in an acute psychiatric crisis is not capable of helping themselves. They're not capable of coordinating transportation somewhere. They are not capable of understanding the recommendations that you're giving them in a lot of cases. So we really need to make sure that we are getting people involved who can help them accomplish those things. I know that we're running a little short on time, so I'm going to speed through some of the rest of these. But the other role of a primary care provider is all the stuff you already do. Diagnose and treat health conditions. You know how to do that. Keep doing that. Don't stop doing that for your patients with SMI. There is some evidence that these types of patients, they can be really frustrating when you're trying to work on these types of things. Maybe their adherence is really bad. Maybe you give them a medication and then they never take it because they think it's poison. Maybe they never do the preventative screenings. So if you have more frequent follow-up and longer visits, that can help build trust and rapport, which greatly increases the chance of adherence. And you can problem solve different things with when you consult with behavioral health as well and caregivers. Again, shout out to pillboxes. You can think about referrals for home health aides or peer support, and I'll give you a resource for that. But the more people that can be involved in supporting someone with SMI, the more likely they are to be able to take care of those physical health conditions. They just might need some additional support. So an example of troubleshooting would be the patient that I was talking about with Dr. Carter, the one who didn't believe that medication was the same medication. She said, well, why don't I just go pay out of pocket for it? And of course, that's not rational, right? It is not rational at all for her to pay out of pocket to get the exact same medication, except for this medication will have Dr. Carter's name on it instead of the other doctor. But if that's what that patient needs to feel comfortable with that medication and comfortable with the care that we're providing, you can roll, excuse me, you can roll with that. You can roll with that and say, okay, is that what would make you feel comfortable? Then we can go talk to the pharmacy and see if that's something we can do. So sometimes you just have to get creative. So the community resources and referrals, Frontline Crisis Unit is a great one for mobile crisis. For a higher level of care, so that's residential or partial hospitalization, we have Highland Springs. And again, you're going to get a handout with all these numbers so you know how to get patients there. For wraparound services, so this is psychiatry with case managers or the ability to come into the home, things like that. Murtis Taylor and Guidestone are good, which might be more necessary for this more severe mental illness compared to run-of-the-mill depression, anxiety, things like that isn't as severe. And then community support. This is great for that maintenance part. Magnolia Clubhouse is a place where people with SMI can go. They pay $1 a day and they can show up and have lunch and get vocational training. And they can talk to people about their lives and build up community and support and have people who are there and checking in on them. So Magnolia Clubhouse is a great resource for that. Thrive Peer Support is a peer support program where people can be assigned a peer, a mentor, who can help them navigate their substance abuse or their mental health needs. So that person will check up on them, try to help them get to appointments, and they can sign up for that service through the website or through the phone number. And it is free to the patient, and sometimes they can even get it covered by insurance. And then Exact Care Pharmacy is a pharmacy service that can help put all of your patients' complex medication into those pill boxes where it gets delivered. And it's like the punch, I don't know what it's called, but it's like the punch out per day. So even if they're coming from different prescribers, So even if you're prescribing something, the psychiatrist is prescribing something, and someone else is prescribing something, a specialist, Exact Care can put them all in one. It gets delivered. It's huge for adherence, literally saves lives. You can talk to your pharmacy colleagues about how to make that happen. I think there are some logistics around it and some hoops to jump through, but once it's established, it's done, right? You have everything set up through Exact Care, and that can be a great way to help your patients who come in and they're like, here's my medication, and then it's a bag, and they're like half spilled out, and you don't know what's what, and you feel like you're having a panic attack. That's when you want to call Exact Care Pharmacy. All right, so I know some people probably need to go, but any questions or reactions to this presentation? Would love to hear from people about if this feels doable or if they have other things that we didn't mention that they found helpful. Oh, and I just saw in the chat that some people were having trouble hearing me. Hopefully it wasn't too bad. Can try different headphones next time. But even if people aren't participating right now, I appreciate you all being here. Feel free to pop in the chat. I'll hang around for questions. I will be emailing out that handout, and I can actually pull it up right now so that people can see it, so you know what you're getting into. And I want to remind everyone that the next integrated care seminar is Wednesday, March 31st, same time. So last Wednesday of the month, 12:30, same Zoom link, exact same protocol and procedure. And the topic will be 5-minute interventions for depression and anxiety. And Sarah, can you scroll through and make sure you got everybody for attendance, just in case some people joined late?
Yeah, I checked to make sure if anyone arrived a little bit late. Everyone should be accounted for. Thank you, everyone.
Excellent. Yeah, so join us next month for 5-minute interventions for depression and anxiety. Definitely a little bit of a different topic. Yeah, let me pull up that handout for people who want to see it. If you just can't wait for that email, you know. Zoom in here. Perfect. So this is the handout that I want people to have on hand in terms of, I figure the best thing you need is like the numbers to call. And so I also added for like non-emergent, typical outpatient psychiatry cases, Psychiatry Network has been a great referral for us recently. They've been getting people in quickly, which is really helpful. Those wraparound care services, Murtis Taylor and Ohio Guidestone. In terms of like what you do with these numbers, so it's always best practice if we can fax a referral to the referring agency. That way they have the information in the chart, they have the patient's contact information, they will follow up. Definitely best practice, especially for this population. If that isn't possible or there's too many barriers to that, you can always give the number to the patient. Even better, give the number to a patient's support person and ask them to call and get scheduled. You can also do it with them together in the room, especially if you call Highland Springs. You can do the intake right then, and they can run through the patient's insurance, figure out what's covered for and what they would be appropriate for that higher level of care, like a residential or an IOP or partial hospitalization. I've had really great experiences getting some of my patients connected to Highland Springs. Sometimes there can be a wait. For kids, I didn't put it on here, but Belfair is my referral for a higher level of care for kids, where I've also had some good experiences, but they do seem to get overwhelmed and backlogged sometimes. And it's better to pick one of these referrals and really walk a patient through it than it is to throw 10 at them, because they're just going to get overwhelmed and call nobody. But yeah, I put that Magnolia Clubhouse on there. They've obviously been kind of partially shut down because of COVID, but they are still doing the something is happening in person every day, even if they don't have all their services available. And I don't think it's walkable from here, but it's pretty close. Dr. Staniff, do you have anything to add?
No, I think great presentation. The only question I get a lot from providers is, what if the patient doesn't want medication, right? And so what are some things, or how can they best navigate when a patient isn't open to recommendations?
Oh, that's a really good question. I'm glad you asked that. So I think that remember all those other roles that we talked about. So, and remember how important physical health still is. So if you can get a patient who is reluctant to engage in psychiatric medications, but they're still following up with you, trusting you enough to talk to you about your medical health, like that is still a win. And you can plant seeds. So sometimes people who have refused medication for years, at some point something clicks, they try it and they stabilize. So on one hand, we can't force people to do things. On the other hand, I don't think we should stop making evidence-based recommendations. And so by that, I mean, every time you see that patient, you can be like, check in with them, build up that rapport, and just be like, how have you been doing lately? And it sounds like some of the things you're struggling with are some of the things I think that talking to a psychiatric provider might help with. So I just want to remind you that if you want to do that, this is where you can go for recovery resources. So I think it's kind of a balance between like accepting that there are, we can't force patients to do things, and also not giving up so that we never talk to them about it again. So we want to consistently remind about our recommendation, but also, still be there as a resource for all the other things that you can do for patients. So focus on everything else that you can do. And if they are coming here consistently for medical care, but they have unmanaged psychiatric conditions, that's impressive. So you're doing something right and something really worthwhile, considering what we know about health outcomes in this community. And talking through the pros and cons of medication, I've had patients who within 15 minutes change their minds on medication. That just happened to me last week, actually, where she told Dr. Carter she would never take a medication. It was like absolutely no deal. And then I was like, let me just tell you a little bit about what we know about medication and why it works and how safe it is and how people find it helpful. And like literally 15 minutes later, she's like, oh yeah, I'll try that. So sometimes you just need to give people some space to explore that with some non-judgmental information sharing. And again, it's often the friends and family who are able to connect them to that care. So if you educate the support people about the importance of medication, and sometimes they get in a crisis, they're hospitalized, they start the medication there, that is an opportunity. If we can keep them on that medication after they are discharged, that's a game changer. But that requires a lot of proactive work, which the discharge planning often leaves something to be desired. But if we can catch patients early and talk to them about that, tell me about the medications you were on. What did you like? What did you not like? Are you going to follow up with that psychiatry provider to make sure that we have a plan? Oh, you don't like these anymore? That's fine. Go talk to them about other things you can try, but keeping them engaged. Well, I don't want to keep people who might want to get to lunch. So like I said, I will stick on here for the rest of lunchtime for people who have questions or anything else. But don't feel like you have to stick around. Thank you all for being here.
Good job.
Thanks. Yeah. And also, if you want to consult about any of your patients who fit in this category, you can send me a task, you can set up a phone call.
Mhm. I had my dissertation chair
Mhm.
always talked about with like serious mental illness or just like working with rapport building and whatever. He said, if they're trying to buy pants, don't try to sell them a shirt. So
Yeah,
like
that's
it's kind
good.
of this idea of
Yeah.
like, don't try to, push something that they're
That's
not
not gonna
already looking
happen.
for. Right.
Right.
So like we have to sell them on the idea of what they actually are looking for relief from. Right. So but yeah, I mean, SMI is scary and hard. So
It is. And it can be really disheartening too. So I think it's kind of hard not to feel really hopeless with
mhm.
some of these patients. And that's why I think with this presentation, I was, even for myself, kind of focusing on like, well, what can we do? What's
Oh,
realistic?
totally. Mhm.
So that you don't get so bogged down in, gosh, this person obviously needs so much more than I can give.
Mhm.
Um,
Work smarter, not harder. That's my life motto.
mhm,
So.
mhm.
All right. Well, I'm going to jump off, but Kathleen's available.
Yeah.
I am available. Thank you so much. Sarah, you are wonderful as well.
Yes, Sarah did a great job helping with the presentation.
Thank you. Thanks, everyone.
So everybody have a good day.
Thanks. See you next time.
Bye-bye.
Yeah, see you next month. Be here before we know it. Yeah, always available for consults, people who are still on the call. So even if it's a patient you haven't seen in a while, but you kind of want to brainstorm how you might help them next time, because we know these patients tend to pop up and then disappear and pop up again, just let me know.